And at the same time, they don't necessarily apply to every situation. So that is how I feel, especially with psychoeducation, is oftentimes we have to not just see the recommendation, we have to see the child beneath the recommendation, the family beneath the recommendation. And sometimes what's ideal doesn't happen. And it's better to admit the reality than it is to just push for something that won't happen. Anyway, okay, that's my entrance into many child psychiatry topics. All right, the things that I'm going to talk about today are things that I say a lot in evaluations. So these are jumping all over. This is not a whole child psychiatry fellowship in 45 minutes. This is like stuff that I just say a lot, so I figured it would be helpful. There are a gazillion more things I can put on here, but these are when I'm doing my evaluations and I'm spending a ton of time on psycho evaluations or psychoed. These are things that come up a lot. So that's what I'm going to go over. You may know some of these, you may not. I hope that at least you find one thing that's helpful. All right, context of evaluation, just like what I talked about earlier. So we have to take into account the child we're seeing and the context around them. Psychiatric disorders are largely sociologically defined, if I'm being honest. What we define as a society is a disordered level. It is very much contextual. So these are things that I want to point out that come up. So if there's symptoms that are highly discrepant in different settings for ADHD, so lots of ADHD at home, but not at school, ask the parents what they think is going on. So this happens the most when I see a Vanderbilt that is, ADHD rating scale that's like really high from home and really low from school. And I'm looking at that going, what is happening? It happens a decent amount of time, I would say. Not every time, but a decent amount. And I think the first gut instinct is often to point to one of the places as a problem. Oh, this is a school problem, or this is a home problem. And maybe it is, but I don't start off thinking that. I recommend if you do see that, approach it asking the parent. Just start by asking the parent, because more often than not, they actually do have a good reason. And I don't think it's an excuse. So at least 50% of the time, I figure out real quickly why there's a discrepancy. So this kid just started a new school. They have no idea who this child is. The teacher has 3 ADHD kids at home, and she knows basically she acts like a paraprovider for ADHD kids at school, even though she's not called that. So her marks are lower. Or what if the child takes medication, it works perfectly during the day, but not at home? So that's when you'll see a discrepancy. So before I start fishing around with what I think, I ask them first, and it's easier. A lot of times parents come in, they feel bad too, because they saw what the teacher put, and they know that you're going to think they might be a crazy parent. There's a lot of guilt and a lot of shame and worry that they won't be believed. So I start off with trying to believe them, and usually it makes sense. My other 2 cents is families come in at different points of trying things. One first evaluation is, sorry, that was my cat. One first evaluation for one person could be in a very different place in the process for the first evaluation for another person. And it's important to keep that in context, because it's going to make your treatment more appropriate and more efficacious. So the kid that comes in that has absolutely, the parents don't know much about ADHD, they've heard of it, no educational supports have been tried, they haven't tried changing anything at home because they wanted to wait until the visit. I'm not saying that they're being inappropriate, it just, that's their starting point. That psychoeducation that you provide, the treatment recommendations that you might give might be very different than the family that comes in and for years they have been trying to do everything to the max already. They have read the blogs, they have gone on Pinterest, they have worked with the school. Like, this kid is essentially getting a therapist and an IEP and everything they can at home and at school. And I'll be honest, that subset of parents, I definitely see a lot, and they usually feel the most guilty, I feel like, coming in, because everything they're trying is not working to the extent. And they were hoping to go someplace without meds or something. They're hoping that they could beef up their parenting skills so that their child wouldn't have a problem. And then their child still has a problem and they feel really guilty. So these are for that family, I talk to them a lot about, they're already doing a lot of stuff, and that is great. I'm glad they're doing a lot of stuff, but that also ends up masking some symptoms. So for that family, what I'll say is, we could keep doing what you're doing and I could add some tweaks. Or at this stage, we're closer to me recommending medication. because honestly, you've tried everything else. And a lot of times for those families, it is a relief, I think, because they came in feeling bad, maybe wanting medication, but also not wanting it. So if you take that family that's already tried everything and you go, okay, yeah, I think they have ADHD. Now read this book on it and send them out. That family is going to be super angry when they get to me because they're going to be like, they told me to read a book I've already read, or I'm already doing all of those things. They tell me, like, a lot of parents will come in, they'll be like, they told me that I have to work on my parenting skills, and I'm already trying really hard. And I feel bad because those parents already feel guilty, and then they feel angry, and then they feel like they can't trust people. So when you're going to recommend the basics, don't necessarily do it to all the people who know the basics. I think about that as a medical professional. Sometimes when I talk to other people, you know, when my mom was sick, they would be like, the kidneys, what they do is they produce urine. And I wasn't trying to be grandiose, but I want to be like, I know, I am a doctor. Could you please get to the point about where she's dying now? So it's easier when people take into context if you take into context where they're at. So asking them what they've done already doesn't have to be a long conversation, but can fill in a lot of gaps and make the treatment more efficacious. Okay, young kids. For young kids, you need to take account into safety the most. The younger the child, the more safety makes a difference in your treatment recommendations. The PAT study is the preschool ADHD study. It was a great landmark study out of child psychiatry. The PAT study showed that preschool children with severe ADHD, that diagnosis was most likely to be valid. So they were going to continue to have ADHD and it was going to continue to be impairing. And for those kids, it is worth potentially treating with medication. I want to tell you a situation, what this looks like. So yes, ADHD can be diagnosed as early as age 3. And I'm sure a lot of people are like, oh my God, I would never diagnose a 3-year-old with ADHD. So since I like working with families and young kids, I probably get to see more of those than other people. And I want to give you an example of what a 3.5-year-old looked like on referral. So the reason she was referred was because in the middle of the night, she kept sneaking out of the house, however she could, going down the street to the gas station, those 24 hours, and buying candy with whatever change she could find. So many times the gas station person called the parents, had the kid come back. And at some point they called Child Protective Services because they were like, this is unsafe. So the mom, when she came to me, the referral was from Child Protective Services, but the mom came to me and she goes, I do not know how to keep my child safe. I'm so happy that Child Protective Services got involved because I will take any help that I can get. Now, that's not usually what you hear from a parent when Child Protective Services has made the referral. So she was like, I don't know what to do with this child. It's the baby. I've had 4 other kids that had some problems, but not like this. So this kid, I saw her and she was like, I mean, she could have been like essentially stuck to the wall, like the ceiling. She was so active. Like she was like Spider-Man just everywhere. And so I was like, yeah, let's do a stimulant for this kid. And so I started it, but I started it really low because that's what I'm going to do. Right. So then I see this kid at follow-up and mom requested an earlier follow-up than I had made. And she said, I think the medication's helping, but not enough. So, I'm like, okay. So then I do this video appointment and this kid, maybe she's 4 at this stage, 3.5 still. They live in like sort of a farmhouse, but next to a busy county route road. So even though it's the farm, it's the rural area, it's really busy on that street, like in the morning. This kid, I'm not kidding, takes the phone. So it's a video appointment, takes the phone, starts running through oncoming traffic with me on the phone as I'm watching cars whizzing by and honking. And she is cracking up, trying to dodge cars. I can hear the mother screaming behind her, chasing her, freaking out. And I'm like, I'm about to see a child die being hit by a car. And I have no doubt those cars all had PTSD when they got to work. Like, that is how bad it was. So of course, and after that, I was like, I think we need to go up on the stimulant. Those are the kids that the younger they are, the more dangerous they are. For that child, she is more likely to die from oncoming traffic or being picked up by a stranger than she is from the stimulant. That's how the talk goes. It goes pros versus cons. Now, of course, stimulants are well proven in older kids, so the risks are much different. But whenever we're looking at a 3 or 4-year-old with, medication, people feel icky about that because the developmental stage is just so rapid that we don't want to mess with it. So I can see why people are hesitant. And I'm not saying you shouldn't refer to child psychiatry. I'm just saying if you see me put a 3-year-old on a med, it's usually because I'm freaked out they're going to kill themselves if they're not on it. Now let's go into subtypes a little bit. ADD is the old terminology for ADHD, inattentive subtype. It's just a terminology thing. If someone reports ADD, you as the professional should put ADHD inattentive type so that you keep up with current nomenclature in the chart. But I tell parents they're the same thing because they're like, well, my sister had ADD, but they say she has ADHD, but she's like my sister. I'm like, yeah, same thing. Parents don't have to know, but you have to know, is how I see it. Girls tend to get in less trouble. So there are fewer behavioral problems on average with girls. And because of that, ADHD is more likely to be missed. Now, whether or not it actually occurs less in girls or it's not picked up on, we're not quite sure. Probably both. So when they're younger, boys are 4 times more likely to get a diagnosis of ADHD as girls. That gets a little bit less as they get older. But it's partially because the boys tend to be a little bit more hyperactive, just on average, causing more behavioral problems, and the behavioral problems are more likely to lead to an evaluation. The girls who are a little bit more inattentive on average tend to be the ones who are not really living up to their potential. They're getting C's, maybe they forget homework, but they're sweet. They don't have the best hygiene. That's the inattentive girl who often will not show up until she's 15 and suddenly failing school now. One thing I want to tell you is hyperactivity tends to improve with age, but inattention stays stable. I sometimes think inattention gets worse, but the studies, when I reviewed them, says that it stays stable on average. That means that the 5-year-old boy who is bouncing off the wall and interrupting everyone, the natural course, regardless of medications or not, the natural course is that 5-year-old bouncy boy is going to be a 15-year-old teenager who does not want to get out of bed in the morning and misplaces stuff and accidentally puts the remote in the refrigerator when he's not paying attention. So the inattention sticks as they get older. That's the symptom that you tend to see in older teens, adults, so on and so forth. All right, treatment. When you're diagnosing and treating, it's like I just said, you want to look at safety. You also want to look at significant impairment in the functioning from the standard expected age development. Everyone can look a little ADHD, there's a lot of times when they can look ADHD. They might even have ADHD, but not need medications. The reason that you diagnose and treat is when there's a big enough gap between the functioning. So if this child probably has a normal IQ, but in 3rd grade, they are functioning at a 1st grade level socially, academically, then that's a big difference. And, sometimes we get IQ testing and it literally is just the ADHD holding them back that much. It may not be anything else. So that's when you want to diagnose and think about treating. Now, why bother treating? I just mentioned it a little bit, but because the longer the symptoms go that are more severe, the more potential problems you might see. So they fall behind. So behavioral disturbances in preschool, okay, maybe you don't treat, maybe they do okay in school, but they don't have friends because kids don't like other kids that poke them in the face. And then now they don't have friends. Now they're going into elementary school, and at school, they're trying to be the class clown because they don't have friends. They're trying to make people laugh. So now they're getting in trouble at the school and they're not paying attention. So their grades are going down. Okay, then they get a little bit older. They have maybe one friend who has similar problems. Those friends go out to a party and without thinking, they accept drugs because they're just impulsive and they say, okay. So this is the kind of way that, I'm not saying it goes this way, but that's the kind of pattern that we want to try and interrupt. So now if a kid is in preschool, they probably have ADHD, but they're not causing problems. The school can work with them. You don't necessarily need to do any sort of medication. Maybe as an adolescent, their grades are B's. I had one girl, literally genius level. I forget what her IQ was, but it was something I'm sure much, much higher than mine. It was like 130 or 140. And she got B's and C's in school. And it was because of her ADHD, legitimately. It was not an intelligence thing. But you know what? The family was okay with that because when she took the ADHD med, she didn't like how they made her feel. And so she and the family decided, we're going to live with B's and C's. Yes, she has the capacity to do higher, but for us, it's not worth the side effects of the meds. the role of therapy in ADHD, my 2 cents, it's pretty much indicated in most ADHD, except for the older ADHD kids who only have ADHD and nothing else. You see a 12-year-old, 8-year-old, and all they have is straight up ADHD. Everything else is okay. Therapy has been shown not to necessarily add more. Ages, one thing I want to go over, and it's often an insurance game. There are 2 medications, two stimulants that can be prescribed under the age of 6, and that is Adderall and Dexedrine, based on the FDA. You can, of course, prescribe them earlier, and I do all the time, other ones. But those are the 2 that are FDA indicated. Often, if insurance gives you a hard time, you start Concerta on a 5-year-old, and insurance says this isn't appropriate for a child under 6. There are no studies. We're not going to pay for it. What you need to do, start the kid with Adderall immediate release because it is FDA indicated. And then if they fail that, then usually insurance will pay for them to go to Concerta. You have to go in a certain algorithm. They don't tell you that. If you start Ritalin in a 4-year-old or under 6, and they ask you for research, you send them the PAT study. So that's the answer. And the weird thing is they know that. When I called insurance once, I was so angry, and I was like, yes, the PAT study. I literally had this other person who knew nothing medically on the other line going, oh, yep, I found that's on the approved checklist. So yep, we'll approve it. So they already knew the PAT study. They just want to know that I knew the PAT study. Now for kids, you don't always have to go to a stimulant. They have some hyperactivity. Maybe it's going to be ADHD. Maybe it isn't. Maybe it's not bad. The alpha agonists do have some good research. So guanfacine, clonidine. It's good to start with that often. I put in stimulant dosing, but I'm not going to go over that today. It's just for if anyone's curious. One last thing I want to add about ADHD. Stimulants haven't been shown on average to raise seizures. I know this because I worked with a neurologist who I frequently asked when I had a kid who had seizures, am I going to make things worse with the stimulant? Parents wanted me to ask. And he was like, Burgundy, I've told you this every time. No, on average, they say just treat with the stimulant. You don't even need to ask me. And then from now on, because I asked so many times, he still to this day, when there's a new article that comes out on it, he sends me an article about how stimulants on average don't make ADHD worse. You can find some good charts to have that are good to have in your office. All right, going into mood disorder. So mood disorders, let's see, I think I go to 9:45, so I'm good. Again, these are the things they're helpful for me as a provider when we communicate, but also things I tell the family a lot. DSM section on mood disorders has been replaced in DSM-5 with separate sections for bipolar disorders and depressive disorders. So mood disorder now, when you use it for our current psychiatry book, means depressive disorders and bipolar disorders. It covers both. And I say this because people love to refer kids for a mood disorder, and what they secretly mean is bipolar disorder. But a lot of times I don't actually know what they mean. So it would really help me if you put other terminology when you're making the referral: mood dysregulation, extreme, mood swings during the day, like lots of intense emotions. It helps if you can break down the behavior you're seeing, because that helps me know from the get-go, what am I potentially looking for? Because just based on the terminology, depression, I used to think this. I'm like, okay, so they're looking for potentially depression. I diagnosed depression, and then I spoke with another therapist who was like, yeah, but I think also a mood disorder. And I was like, what do you mean? I did diagnose a mood disorder. It's depression. This is how I've realized people, when they use mood disorders, they're not using the current terminology. Now, the bipolar type disorders didn't change in the DSM. However, we got 3 new depressive disorders: DMDD, persistent depressive disorder, and premenstrual dysphoric disorder. The only one I'm going to go over today is DMDD because I see it a lot. Again, this is what I talked about with the mood disorder. Please, for the love of God, describe what you're actually seeing. Or if you want to put in bipolar disorder, just whatever you do, don't say it to the parents. If you say it to me, I will try and figure out what is going on. But then parents come thinking something is bipolar disorder, and I have to backtrack on why it isn't. So just use the basic behavioral descriptions if you can, when you can. And I put in here, it's like if you put in a referral for someone being neurotic, like that's the old terminology. I'd probably get what you meant, but I also may not get what you mean. A common question that I get is, when is it depression versus an angsty teenager going through puberty and other stuff? This is when I say you have to know the developmental aspects. You have to know them. You have to know what is normal for a teenager that is different from a 3-year-old. It helps to see that. Beyond that, it's also helpful to have an understanding of what is within the normal spectrum for each age group. So a 3-year-old who brings their stuffed animals everywhere and talks to imaginary animals and does cartwheels during the visit, that could be fine. A 17-year-old who does that, probably not fine, right? That's outside the norm. So I put in here, for example, 14-year-old who doesn't want to get out of bed in the morning, wants to stay on the phone at night, has a boyfriend, sneaking inappropriate but funny YouTube videos by itself. That's pretty standard. That's like, that should be just a picture of a teenager nowadays. But what about the 14-year-old girl who never comes out of her room, wants to sleep all day, refuses to go to school, sleeps in school, is snapping at everyone, losing friends, and is looking up how to kill herself on YouTube? So that should make you be like, ooh, this might be going a little too far. Meanwhile, coming from whatever your role is, if you're OT, PT, therapy, whatever, you can give them guidelines based on your role. So, like maybe if you are a therapist, you might say, hey, they need more exercise more. I'm not saying that you would say that, but you can start with your basic educational recommendations. But if you're really concerned about this kid having a moderate to severe depression, that is when they deserve a little bit higher level of treatment. And by higher level, I don't mean better. I just mean more intensive or severe. All right. Again, developmental aspects make a difference. This chart is lovely, but I'm not going to go over it. One thing I want to point out is irritability is common in kids with depression and anxiety and less likely with adults. For the snappy, irritable 6-year-old who is annoying the heck out of their parents for suddenly arguing back and not being happy with anything, that kid's way more likely to have an anxiety disorder than a behavioral disorder. All right, now we're going to go into the treatment. This is the QPR method. This is something that everyone can do. So, and you can go to the website. This is not technically a therapy. This is an intervention. So this is something you can recommend for parents, but something you can do as well. The QPR method is supposed to be based on CPR. So CPR for people getting, like having a heart attack, dropping down. QPR for people you're worried might be suicidal. Q, ask them if they're thinking about killing themselves. You can put it in many different ways that you want. Are you thinking about not being alive? Whatever. P is persuade. So I'm going to be honest, my common persuasion one, it sounds a little bad, but when I get a kid that's like, I can't quite tell if they're telling me the truth, they're maybe more depressed than I think, I make them promise me that they're not going to kill themselves until the next appointment. It sounds a little funny, but usually, I'm like, hey, 2 weeks. I did this just the other day. 2 weeks, you're not allowed to kill yourself, and then we'll rediscuss the killing yourself part at the appointment. It sounds bad, but I feel like it gets through to a lot of them. That's not for every kid, but maybe tell kids like, hey, I'd be really upset if you died. And then finally, refer. Try, if someone tells you something, try and get other people involved, whether that's parents, whether that's professionals. This isn't about doing it right. The reason this has been shown to help in evidence and research is because children, whoever, adults who are depressed often feel alone, isolated, and like they aren't being seen and they aren't known. So just you asking, even though it can feel awkward, clues them in that someone might get them. They've also shown with kids, I don't know, if they answer I don't know to suicidal questions, that means yes. The only thing that actually is significant is if they say no, that usually means no. But the point is you can see here at the bottom, since almost all efforts to persuade someone to live instead of attempt suicide will be met with agreement and relief, don't hesitate to get involved or take the lead. Try saying, I want you to live. I'm on your side. We'll get through this. You don't need to fix everything. You don't need to freak out that a psychiatrist isn't there right away. Just by you going through some of these steps, by asking a kid, by telling them you want to live, by saying you're going to look into stuff, that can give them enough hope that you can literally essentially prevent suicide. I'm not saying every time, but you can break a link in that chain. Now, when we go into treatment, the research strongly suggests that moderate to severe depression in children and adolescents benefits from meds and therapy. So I'm sure in all the fields you guys have like, the hypertension recommendations for when to start hypertension medication. You have recommendations for when to start a cholesterol medication. And most people, I don't think they look at those recommendations and they think, oh my God, what are we doing? Most people anyway. However, with the recommendations in psych, they're pretty clear cut in a bunch of our studies that moderate to severe depression, by doing meds and therapy, the benefit to risk ratio is 17-1. So it's pretty high up there. Now, don't ask me how they calculated that. I cannot remember math, but it is in there. So in our 3 landmark studies, if you ever want to look them up, the Tordia, the TADS, and the ADAPT. So these are big studies where we looked at, are meds safe for kids and when are they indicated? Now, bottom here, I put mild depression, therapy without medications can be considered. I put this in here for you to look back later if you want, but these are big therapy points from the studies. I want everyone to know SSRIs are not killing children. In general, they are saving lives. We know about the black box warning. SSRIs can increase suicidal ideation, right? It says suicidal ideation, not suicide. It does not increase suicide. It reduces the risk of suicide. It sometimes increases the thoughts. And in the studies, the old studies, it only went up 1 to 2% in the population. This is not suddenly every child is going to contemplate killing themselves suddenly. It doesn't happen much to me. And often it's kids who are already having those thoughts and they get like a little bit more activated and they come out. So I tell parents very clearly, this is not going to kill your child. This is going to prevent them from killing themselves more than likely. But yes, there is the risk of suicidal thoughts and you need to stop the medication and let me know right away. New or considering suicidal thoughts, the medication should be stopped and the parent follows up with the doctor. I want you, if you're in medicine, I want you to approach it with the same level of anxiety and worry that you would have for amoxicillin causing a drug rash. Same sort of, it sounds scary, but it's basically the same thing. Probably a drug rash turning into Stevens-Johnson's is similar to a kid having suicidal thoughts and that leading to death. So you don't have to deliver it to the parents with like, by the way, your child might also kill themselves. That's a horrible bind to put them in. And also, sorry, my camera's getting weird. It's also not accurate. One reason I know this is that when the FDA came out with the black box warning, there was a major spike in suicide. So much so that immediately people thought maybe we should get rid of the black box warning because a lot of people were so afraid of it that they stopped prescribing it. And the teen suicide rate, the children's suicide rate just shot up. And I know it's true that people are afraid of them because they've shown even kids who meet criteria, on average, PCPs are not going to prescribe SSRIs for moderate to severe depression. I'm sure many of you do. I'm not trying to knock it and say like no one here is comfortable with depression. However, there's sort of this like feeling of voodoo with and fear of SSRIs. And I'm sure there are many reasons for that, partially because in psychiatry, we've made a lot of mistakes. We used to call homosexuality a disorder in our early DSM. So we haven't always done the best in making people feel better. But at the same time, what these articles go over is that for the kids that actually qualify for meds, they're way less likely to get them at the PCP level. And I think it's partially because of that fear that is largely unfounded, if I'm being honest. All right, except for paroxetine. Don't start it in kids. That's the only one linked with potentially increasing suicidal gestures. Paroxetine, Paxil. If someone's already on it, we're allowed to keep them on it, but don't start it. All right, now I want to go into DMDD. DMDD, disruptive mood dysregulation disorder. I'm going to be honest, when this first came out, I thought this was a bunch of crap. Pardon my language. I thought this was so stupid. And I was like, this doesn't exist. And I'm going to be honest. I remember shortly after that came out, the first time I saw a DMDD kid that I knew that's what it was is when I was, I think, a resident on the unit. And I saw this 8-year-old go through every emotion in the book within 20 minutes in our interview with them. And it was like, I felt like I was watching a horror movie, like they were possessed. And I was like, oh, that's DMDD. Okay, it does exist. And so the DMDD kids, so what DMDD is the reason it was created is because we realized when we were going through all of our psychiatry knowledge before we came up with the DSM-5, we realized that we're horrible about picking out who has bipolar disorder in kids. We're just not good at it because the majority of kids diagnosed with bipolar disorder as adults didn't meet criteria. And that's not how it's supposed to happen. It's like you can't diagnose someone with, I don't know, Parkinson's, and then the next year they don't have Parkinson's automatically. Like it's something that should stick. So we realized, yes, I'm sure pediatric bipolar disorder does exist, but as a field, even in psychiatry, we cannot pick out who is going to end up having it, even if they look bipolar now. The studies show this over and over again. We are not good at picking it out. So we had to, but there's this group of dysregulated kids that for all intents and purposes look bipolar. Their moods are all over the place. The mood swings are up and down. It's intense. There's dysregulation to the max. So that subset of kids exists. And what do we call them? And that's how we came up with disruptive mood dysregulation disorder. It is not necessarily a placeholder for bipolar disorder. They don't necessarily end up having bipolar disorder, but it's a way to say this kid gets wicked dysregulated. And I explain that to parents. For me, a clue in is if I ever get a referral from a parent and they think their kid's bipolar, more often than not, it is going to be DMDD. Not always, but it usually is. So that's a clue in for you. Concerned about bipolar, think DMDD. Do not think bipolar first, unless they're like 19 and I don't know, they're like walking around outside naked and speaking in tongues. That was one of my bipolar patients at 16. Yeah, okay, maybe. But other than that, think something else. It can't be co-diagnosed with ODD. I'm thinking that'll probably change in the future, but it's thought that every kid who has DMDD pretty much already meets criteria for ODD, so we can't diagnose them at the same time. It's seen as like an extreme version of ODD. I think they're going to show that it has different properties, so we will be able to co-diagnose in the future, I think. That's my guess. But as of right now, you can't. So some points I want to make. It qualifies for kids who are 6 to 18. If you see a dysregulated 5-year-old, maybe they're going to have DMDD, but you can't call it. Symptoms are usually seen by around age 10. This is when I see it the most commonly is, I would say 8 to 13 is when the DMDD kids are most likely to present to me. The symptoms have to be present in 2 settings. So not like ODD, 1 setting potentially. DMDD is 2, but usually one's worse than the other. So they maybe lose it completely at home. And at school, they kind of lose it. They cry a little bit more. They get in trouble occasionally, but it's not as bad. That would be consistent with DMDD. You see here, they are supposed to have at least 3 outbursts a week, or the outbursts have to be so disproportionate. Like, you move one of their things slightly and they end up punching and kicking everyone. That is disproportionate. They also have irritability, like like a lot of irritability. These are the kids that when I get them on for interview, they are annoyed at me for looking at them. So the irritable, angry mood is really there. Now, if you see a kid who's having outbursts and gets dysregulated easily, but in between those times, they're not, I just had a little kid like this. They're not angry. They're sweet and happy. That would be more consistent with like low frustration tolerance due to ADHD, for example. The DMDD kids are if you can picture what an angsty 7-year-old looks like, that's DMDD. If you can picture Edgar Allan Poe as a 7-year-old, probably DMDD. They're just dysregulated. Anyway, that's not exactly like perfect terminology, but that's how I think of it. And again, this goes into don't call it bipolar disorder. Please, God, don't call it bipolar disorder. If you do, don't tell it to the parents. It's not bipolar disorder. Unless for sure, I would say I've seen in kids under 18, I've probably seen 10 to 20 cases of what I saw was true bipolar disorder, that I knew 100%, hey, this is bipolar. One was the girl walking around naked, speaking in tongues, writing upside down on her stomach. It's interesting. The parents came in, they thought she had a new onset personality disorder. It usually goes the other way around. She was manic. The manic people in the unit often stay up all night dancing half naked in the hallway. And it's an episode. It's not 20 minutes. It's not 40 minutes. It is like a week. They suddenly don't have sleep and it's all over the place. All right. So DMDD kids refer for therapy, but also the type of medications we're using are still coming out. So because this is a new diagnosis, we're still figuring out what to do. Right now, the main recommendation that they're figuring out in research is most kids have ADHD who have DMDD on average. Treat the ADHD aggressively because by reducing the impulsivity, it helps them handle their emotions better. So if you have a kid who has DMDD and ADHD, make sure you are hitting that ADHD hard. I usually diagnose them at the same time. I have one kid who it's gone the other way, where I diagnosed her with anxiety and then depression. And that's when the therapist was like, I think she has a mood disorder. And we went through that whole, what do you mean? And it occurred to me, this girl did fit criteria for DMDD. And the more I talked to her, the more it made sense that she had missed ADHD also. So I put her on a stimulant. She's doing beautifully. And this is a parent that we couldn't quite get meds right for like a year and a half. So you can also just treat the main symptoms. If they're anxious a lot, and that seems to really bring out their dysregulation, treat the anxiety. So there's no gung-ho recommendation. They're showing evidence for the stimulants, treating ADHD, then some evidence for citalopram came out recently in a study, but often any SSRI works. So I want to go briefly, moving on from DMDD. Let's see, I still have 10 minutes. One thing I want to say is with supplements, they can be good. There's some evidence on them. My 2 cents is I don't prescribe them for my patients. I don't recommend them for my patients because they're poorly regulated. I don't care if they have evidence. Yes, fish oil has evidence. N-acetylcysteine for trichotillomania has evidence. Melatonin has evidence. Yes, I might recommend melatonin or N-acetylcysteine because the other options are not the best. But everything else, I let the parent bring it up to me. I don't go out of my way to recommend it because they keep finding whenever the FDA finally comes around and checks the supplements like every 10 years, they find that what they think is in them is not in them. So I always joke, like, if you want to give your kid St. John's wort or 5-HTP instead of a depression medication, what you're saying is, I'm so uncomfortable with SSRIs that I would like a less regulated, less effective, more expensive medication. To me, not saying that's always the case. Do I give my own kids supplements? I do. I give them iron because they won't freaking drink the iron they're supposed to take. I bought something on Amazon, no clue what's actually in it, but you know what? That's what I do. Now, but as a professional, that's what I recommend to parents. So the pros and the cons. All right. I want to put out a note. If you guys don't know this, there's a new suicide crisis line, 988. It's supposed to be like 911. All right. Now let's get into PTSD, trauma and PTSD. I'm sure we can take just 10 minutes to cover all of PTSD. Just kidding. Not really. But so talking about PTSD and trauma is going to be talking a lot about talking about it. So there's an explosion of interest and understanding about trauma right now. And the DSM is sort of in its infancy regarding the topic. It is, PTSD used to be listed as an anxiety disorder just in our last DSM. And then suddenly people are like, oh, I think this is maybe a separate disorder on its own. So we're a little behind the times. So now we have the category trauma and stressor disorders. So I'm really glad that people are figuring out trauma a lot more, how it impacts people. There's a lot of different perspectives. There's a lot of knowledge coming out. In psychiatry, we are behind the times. Now, trauma does not equate PTSD. If you take anything from here, hopefully you take this. And this is something that I often have to go over with parents. Because a kid had trauma, because it impacted them, does not mean you call it PTSD. That's like saying a kid who is throwing up has influenza A. Yes, they might, but they do not equate. Trauma is common, PTSD is not. So they've shown, you can see these huge percentages of kids that have gone through at least one trauma. So for the 14 to 30, 43% of boys who have gone through a trauma, 1 to 6% develop PTSD. So it's calling it just PTSD because they've had trauma. I get what people are doing. I see this a lot. but they don't fit criteria necessarily. Now, sometimes they meet criteria when they see the PCP or the therapist, and then when they get to me 6 months later, they don't meet criteria anymore. That does happen. They used to have nightmares, they used to have flashbacks, and now when they get to me, they don't. So it was never a wrong diagnosis. It's just now it's gotten better. What I tell parents is literally, it's not that your child doesn't have PTSD, because a lot of times I have to walk back the diagnosis that has been given to them. It's not that they don't have PTSD. It's that we don't have a name for it yet in the DSM for how the trauma has impacted them. Like what, a handful of disorders to describe a gazillion types of trauma and responses in the DSM. It's not accurate. We only have a couple. And so when I tell parents this, I say, you know what? I do think the trauma has impacted them. I do think it's changed their relationships. I do think that this makes a difference for them. I totally validate that. That being said, they don't meet the very narrow criteria of PTSD. And, you know, I might put abuse or trauma in there, but in the diagnoses, but I don't put PTSD just because there was trauma. And one reason is abuse is common. 1 in 4 children experience abuse or neglect in lifetime. And that's the number we know. Just think about what we don't know. The fatality rate is pretty high. By that, I mean 2.2 per 1,000. I guess it's not extremely high, but for me, it's a little bit upsetting. It's hard to know these statistics, to talk about trauma and abuse being common, but sometimes it helps kids to know this so that they don't feel alone. And also helps families to know this because there's a lot of trauma and abuse out there, which is sad, but people can still grow up and live contented lives. That's the good news out of this. We're dealing with a population that has been traumatized for a long time and has lots of different traumas, and yet people can grow up. I'm not saying they're going to be perfect or anything, but they can live happy lives. I feel like for parents of foster kids, that kind of stuff, that's a helpful thing for them to know. So it's sad to talk about the statistic, but amazing when you think all the people, you know, for every 3 people you know, or 4 people you know, there's one that's had some sort of significant abuse. And then the number, and this partially comes out of a big studies that we have called ACEs. I'm not going to go into ACEs, adverse childhood experiences, but it is a term that's important to know. It's what we're learning about the amount of specific negative experiences a child has, the more likely they are to have various problems, health issues, relational issues, mental health issues. So the number of types of traumas, the number of abuses does impact in the future, that their future is maybe going to be a little bit harder. Again, doesn't take away all the hope. So again, there's hope. Children can, and they do recover from traumatic events. I'm not trying to invalidate them, trying to invalidate anyone dealing with it and being like, your kid didn't experience anything horrible. They did. The fact of the matter, though, is they can still be okay eventually, which I find very helpful. A critical part of children's recovery is having a supportive caregiving system, access to effective treatments, and services that are trauma-informed. And what do I mean by that? So let's say you're uncomfortable trauma or PTSD is some sort of, as a provider, like how do you deal with that? It's actually like more is less or less is more. You can make a big difference by asking about their trauma, their PTSD in a sensitive way and respecting them in a sensitive way. So you don't have to go and fix their trauma. You can't take away what happened to them. You don't need to say the perfect thing, but you can help by being an adult that they see routinely, so PCP therapist, whatever, who they can come to. Just knowing that they have a trustworthy person that they can talk to, even if you don't talk about it, that makes a huge deal for trauma. So you can see here, trauma-informed pediatric care. Look at these things. Minimize potentially traumatic aspects of medical care. Okay, so it is a 15-year-old who has been sexually abused for a long time. Before you say you need to immediately do a gyne exam to check for a bacterial infection, that might be a kid you talk to a little bit more about the pros and the cons, and you think maybe about treating differently. It's that kind of stuff. That's the psychoeducation piece, but it's just taking into account what's going to be hard. When I have a kid with medical trauma, they've been through a gazillion doctor's appointments, they had surgeries, and I want to get labs. I think really hard about getting all the labs at once. And I tell the parents, hey, these are the labs I recommend. but I don't know if it's worth your child going through trauma to get them, or if it is, we should figure out a plan for it. You can see here emotional support, identifying family needs, screening, talking about coping skills. We don't want to re-traumatize the trauma patients. We can't fix it, but we can not re-traumatize them. This is probably one of the bigger things we can do. Being treated as a number. So a kid having to continually retell their story. Being seen as a label. The kid having no choice in service or treatment, or the family. I've had so many people come to me and they said, you know, my kid had, when they were put on a stimulant, they ended up punching everyone and feeling horrible. And the doctor that we saw just said, yeah, start them on a stimulant. And we felt really mixed about it. I'm not saying that's PTSD, but that is a bit re-traumatizing because you're taking away the control. The more you can give information, the more you can give not just recommendations, but pros and cons, the more that you can allow that child or that family to be involved in shared decision-making. Yeah, if you say the kid has ADHD and the parent wants Xanax, I'm not saying that you should do that because you're giving them control. Saying you talk about the risks and the pros and the cons. You don't have to come up with the exact answer. Involving them more is helpful. Again, PTSD, going into it, trauma is common, PTSD is not. So there are technical criteria. I don't want to go into them too much, but if you're going to diagnose PTSD, I hope that you're looking at all the specific criteria. One difference I want to say, DSM-5 versus 4, is that we added in some components in the DSM-5. One of the things we added was learning that the traumatic event occurred to a close family member or close friend. So this is almost like vicarious traumatization, right? We did not have that in the previous one. In the previous one, they had to directly experience it. The other one we had is that we've added is experiencing related or extreme exposure to aversive details of the traumatic events. So, and I think it's appropriate for the world that we live in. When you think about all the stuff you hear and how much vicarious trauma people can get, especially with social media. I had this girl she was friends with a guy and she was going to go to his graduation party. It was a huge graduation party. He invited like everyone on the block. Everyone loved this kid. He was some, like not popular kid, but just got along with everyone. She really wanted to go, but she couldn't because she had some commitment that she had to go to, like someone's wedding. So what happened was at this party, this kid ended up being murdered by someone. It's a weird story, but they ended up being murdered and the person doing it filmed it and put it online. So what ended up happening is this girl got to see and hear about this murder of her friend. I don't know if she actually watched the video. I think she was too afraid to, but she heard about it. And that gave her PTSD, legit, like flat out. And I saw many kids from that area that also experienced it. It was on video. So that's in that situation. It didn't, even if they didn't see it, maybe they heard about it and it was their friend, that kind of stuff would qualify. All right, treatment. We're almost there. What can you do? I've already talked about it a little bit. You can be caring. You can give them more options. You can go over the risks and the cons to see if for them it's worth it. So if I have a kid who is going to blow up if they need to get their lipids checked because of various reasons and they're on Risperdal and they're skinny and I haven't seen any problems, I'm like, you know what? I'll put it in. If you can do it, great. If not, it's not worth traumatizing this kid to find out about lipids. Now, maybe they gain 400 pounds. That might push me in that direction, but it's all pros and cons. There's not a black and white answer to these things, even if you want it to be. So let's say, for example, also you want to include the family. So I talk about the kid, but I also talk about the family because supporting the family is supporting the child. So let's say there's a kid who's recently diagnosed with, he was hospitalized for DKA, had diabetes. Let's say the dad is angry. The doctor missed this. They didn't think it was this, whatever. Checking in with the dad and just saying, how are you feeling? How are you coping? And again, not in a BS way, but in a genuine way where you're not going to get defensive. You're going to be like, oh my God, I can't believe that happened. Even if a parent seems calm and put together, checking in with them. I've been surprised. Some parents can really keep it together and you don't know, but just showing you are curious about them, ask. So how's your family coping? Who's having a difficult time? Are you eating, getting sleep, taking breaks? Pediatric providers play a big role. So pediatric providers are trusted adults who are seeing children often for routine, non-judgmental reasons. They are uniquely positioned to ask children what they have experienced and to respond calmly. By being in this position, they can make a big difference. So just by asking, sure, you can put in a psychiatry referral, but what I'm saying is that you asking, you caring can be almost treatment in itself. It's not your role to solve it. It's not your role to fix it, which can be hard for us in the caring professions or in the medical professions. How do we stop it? There isn't the one thing usually, but being there for them can help. Also, treat the other things that are going on. So it's easy for someone, I've seen this a lot in providers. They're like, okay, if a kid has anxiety or PTSD, they cannot have any other medical problem. It is all anxiety. So, sorry, my cat is deciding to walk around here. So, for example, they have upset stomach all the time. They have headaches. They're puking. It's anxiety. So we're going to send to psychiatry. And I look and I'm like, has anyone tried an antacid? And no, sometimes they have, sometimes they haven't. Yes, it might be caused partially by the psychiatric condition, but then it's a cycle. We actually don't know what came first. What if they have really bad GERD and they vomit? And then they're freaked out by vomiting in front of people, and now they have anxiety. Treat the additional things. That's what I'm saying. All the other recommendations. Therapy is recommended, especially trauma-informed therapies, if you have that in the area. A lot of the therapies are dependent on the type of trauma and the age. So 4-year-old, instead of sending to TFCBT, you'd probably do parent-child psychotherapy if you could. EMDR is good evidence in adults, and there's some evidence in kids, but it's still emerging. So I think it's fine to do it, but it's still being researched. There's no FDA indicated medication for PTSD in children. In adults, there are. In children, there aren't. That doesn't mean it won't help. The research says do an SSRI. It says that they would probably benefit. But just so you know, there's not an FDA indication. Make sure you treat comorbid conditions. More often than not, you are going to see PTSD and depression, PTSD and anxiety. It's very often when you have one disorder that it predisposes you to getting another disorder because of the process. Make sure you treat the other disorder. So let's say they have PTSD and now they're depressed. They're not coming out of their room because of what they experienced. They're not taking care of themselves. We don't just call that PTSD. We call that now depression on top of PTSD. So it might be due to the PTSD that they got depression, but you're going to treat the depression with an SSRI. That's what I would say in therapy. Now, at the end, resilience. Don't lose hope. Remind families not to lose hope. Treat what you can. Make sure you join with families, collaborate in teams, partner with schools so that the kid feels like they have a team. The family feels like they have a team, not just that they're trying to organize all these different people they're getting referred to. So resilience is associated with social, cultural, family, and individual aspects, which is in line with the multi-system approaches described by recent resilience theories. So basically, yes, help the kid, but helping the family, treating what you can, all of these things are helpful. So you may think treating a kid's GERD is not treating their PTSD, but in some ways it is. It's chipping away at those sensitivities. So just keep that in mind. All right, now I'm done. We have 6 minutes.
Oh, great. Well, we'll dive right into questions. We had a number of questions come in. I find as a general pediatrician that it's often hard to figure out a diagnosis in kids that are irritable, angry, or dysregulated. I feel like it is often anxiety, but how do we rule out other diagnoses like DMDD, ODD? What is the best objective screen to use? PHQ-9, GAD-7, Vanderbilt, or another screen?
That's a good question and a tough one. I use scared scales. That's what I will recommend to everyone for anxiety. Scared scales, usually 7 and above. They're free. Go online because they are more comprehensive looking at anxiety. So yeah, I sometimes have that question too. Is this anxiety? Is it DMDD? Is it both? When it comes to scales, the ones that and the thing is clinician evaluation, always a careful one trumps screeners. That's the interesting thing. So we can do screeners to help us figure stuff out, but at the end of the day, we also figure stuff out on our own And that trumps what the screener says, because the screener doesn't take into account context of everything. So I would start with the scared scales. If they are off the hook, if they are super high, and you can find the scoring online, then I would think there's an anxiety disorder, at least, more than likely. But when I'm going for evaluation, it does take some careful asking of questions, I'll be honest. So DMDD, so with anxiety, and sometimes I get it wrong, this is the hard thing. So with anxiety, I am more likely to see the dysregulation around anxiety provoking situations. Now, the child may not say it, but what I do is I try and figure out what they're getting dysregulated about. What is the pattern? So, and sometimes parents don't know if it's anxiety provoking, but they'll say, yeah, every time there's a transition in their schedule, they freak out. I had one of those the other day. Anytime there's something off from the schedule, they get really upset. Now, that kid ended up having anxiety and DMDD, but if the triggers seem like a pattern of things that would cause anxiety, that's when I usually start with anxiety. Now, if a kid is just frequently irritable and, how do I say this? The level of dysregulation just seems higher. The anxiety kid is like snapping and being mean. The DMDD kid is looking like Dr. Jekyll and Mr. Hyde. And when we're talking about comparison, I'm not trying to call a child that. But if the dysregulation is that intense, if they are shutting down the school from their outbursts, if they are punching kids in the face, that level of, and they're dysregulated at the time, that severity is going to point you more towards DMDD. There might also be anxiety, but I would look for what is leading up to the dysregulation. The DMDD kids just get dysregulated about everything for no pattern. If you have a parent that's like, we just don't even know, they're just angry all the time and just randomly something sets them off, even things they like to do, that's going to point you more towards DMDD. But to be totally honest, more often than not, they probably have both. Sorry, I don't know if that actually answered it. Scared scales, do scared scales.
Okay, thank you. One comment was, putting my 8-year-old on an SSRI saved his life and mine. So I thought it was a good comment to share.
I'm going to be honest, two cents I want to say on that. My cat is on Prozac, and I have to say, she's like a new cat. And at first I was like, every once in a while you're like, is this placebo effect with SSRIs? And I was like, okay, if Prozac can help my cat, it has to be doing something. All right, sorry, keep going, coffee.
Can DMDD be co-diagnosed with ASD?
Technically, yes. That's a great question. I have found this is what happens. It can be co-diagnosed, but you have to be pretty sure that they definitely have both. And that is not going to be often that you know that they definitely have both. So the way I do it is, if I don't know if they have ASD, I give them DMDD. Then if they get diagnosed with ASD, I usually say, okay, it's probably irritability due to autism. So I usually pick one or the other, if I'm being honest. And for you to pick both, it's just like ASD and social anxiety disorder, both can coexist, but you have to see like clear-cut evidence of both. And if you can't, if they have ASD, I'd stick with irritability due to ASD. If they don't, I would stick with DMDD. No good, real good guidelines. But hopefully in the future, when we have more research on DMDD, we'll know a little better.
Okay. So let's see, we'll try to take one more. We had a number of questions we weren't able to get to. So I can pull these questions and we can kind of look through later if we want to get some responses out. But one more question is, are you seeing more young teens, 14 to 16, being diagnosed with ADHD?
Yes. There are a couple of reasons for that. I'll try not to take your time. I can also answer questions at lunch if people want. And then in the forward remarks, we're going to have time to follow up on stuff if you're curious. I am seeing more ADHD across the board. I think it's multifactorial. One, we're more aware of it. Two, inattentive symptoms are more, if a kid starts with inattentive symptoms, they are more likely to miss it. Often ADHD, the reason that we see ADHD happening is because there is so many demands that it outweighs their attention. So the inattentive kid who could get by in 3rd grade, maybe the demands of, 11th grade make it much harder for them to get by with the demand. So that's when we start to see that split. And then we look back and we see they've had those symptoms at all times, but maybe they didn't have homework, so they didn't finish it. So I think part of it is it's the bias of girls. It's the bias of if they're not behaviorally acting out. It is because we're not perfect at identifying who has ADHD. There's also a theory evolutionarily that ADHD kids grow up to be ADHD adults who have children earlier for many reasons. So there's thought to be like twice as many generations of ADHD in one, I want to say normal, typical generation. So we're seeing more and more and more and more, because if they're all the ones having kids at 20 on average, and the population is on average having kids at 30, we're seeing more of those, which means we're catching all of them at different times. And I'll stop talking, but we can talk about stuff later too.
All right. Well, we'll now take a short break. We'll resume back at 10 a.m. So grab your coffee, refill your drinks, and stretch, and we'll see you back at 10.
Can I answer one more thing while people are stretching?
Yeah.
Coffee's like, oh my God. Yeah, one thing I wanted to say about that, I actually had this in my slides and I took it out. You guys can go. This is not exciting. But if you diagnose a kid with ADHD after the age of 12, the most important thing for you to do to figure out if they have ADHD is to go through a developmental history and figure out what they were like when they were younger. So above all else, if they have new onset symptoms at 14, that's kind of weird. However, a lot of these kids who had symptoms, you look back and let's say maybe they were 7 and they never did well in school. They had few friends because they were really impulsive. They couldn't pay attention to stuff, but people made it work. So anyone who diagnoses after the age of 12, you can diagnose ADHD at 38 if you want. However, the symptoms need to have started before 12. That's the important thing. It's good if you can document it, but you need to go back and at least come up with a case. If they're a straight A student, paid attention to everything, and they have suddenly ADHD symptoms at 14, that's different. That's like you're seeing depression, probably. Okay, now I'm done. Go break.